Oxygen therapy is widely used in hospital medicine and can be administered in a variety of different ways. Though most people will think that they are generally familiar with how oxygen therapy works, there's a few key points to bear in mind with this very important topic. There are four key principles to be familiar with in order to understand oxygen therapy. Firstly, the oxygen that's coming from the wall or from a canister is 100% oxygen. Secondly, the term peak inspiratory flow rate is used to describe the maximum rate of airflow into the patient's airways when they take a breath in. At rest for most people, the peak inspiratory flow rate will be around 20 litres per minute. In other words, this is the maximum speed at which air will flow into the airways during a breath. This is not a rate that is routinely measured outside intensive care settings, however, the principle is important to acknowledge. Thirdly, the fraction of inspired oxygen, or FiO2, is the percentage of oxygen found within the airways. The purpose of oxygen therapy is to increase the FiO2 within the alveoli, thereby increasing the concentration gradient between the alveoli and the blood, allowing more oxygen to diffuse into the bloodstream. Finally, there are two groups of oxygen delivery devices, fixed and variable. Variable delivery devices cannot guarantee the FiO2 that is achieved. This includes a nasal cannula, Hudson face mask, and non-rebreather mask. Venturi masks are an example of a fixed delivery device, and we will discuss how this is achieved later on. The way in which these four principles fit together in a clinical context is best understood through an example. Here we have Brenda, a 68-year-old woman with a community-acquired pneumonia. To begin with, her oxygen saturation is 89% on room air, and she is working hard to breathe, with a peak inspiratory flow rate of 40 litres per minute. She's then started on 4 litres per minute via a nasal cannula, which brings her oxygen saturations up to 96%, and she begins to breathe more comfortably with a peak inspiratory flow rate of 20 litres per minute. Let's look at this another way. This is what is happening when Brenda has a nasal cannula on at 4 litres per minute. As her peak inspiratory flow rate is 20 litres per minute and the flow rate from the nasal cannula is 4 litres per minute, it means that she's getting 4 litres of 100% oxygen and 16 litres of room air at 21% oxygen. When you plug this into this formula, you will get an FiO2 of 36.8%. You don't need to worry about the specific calculations. The point that I'm trying to make is that for variable flow rate devices, the FiO2 achieved depends on the proportion of the peak inspiratory flow rate that is made up of the oxygen being administered by the device. To illustrate this point, let's see what happens if Brenda's breathing gets worse. Let's say she remains on 4 litres per minute via the nasal cannula and she starts breathing harder with a peak inspiratory flow rate of 40 litres per minute. This would mean that the oxygen coming through the nasal cannula will account for a smaller proportion of the total air that she is breathing in. As such, when we plug it into the equation, the FiO2 will have dropped. If we then decide to change her from a nasal cannula to a 15 litre per minute face mask, a greater proportion of the air that they are breathing in will be 100% oxygen coming from the face mask. This will mean that the FiO2 achieved is around 50.6%. We're now going to talk through the different types of oxygen delivery devices that are commonly used and how they work. Firstly, a non-rebreather mask tends to be the first option that is used in patients who are acutely desaturating. This is because it's the device that delivers the highest FiO2 of those available on the wards. There are a few key parts of the non-rebreather mask that I'd like to focus on. It differs from other face masks in that it has a reservoir bag and two one-way valves. One valve is between the reservoir bag and the inside of the mask, and the other is between the inside of the mask and the surrounding atmosphere. The oxygen flows into the space between the reservoir bag and the mask. Before applying a non-rebreather mask, it must be primed. This involves placing your finger on the valve between the reservoir bag and the inside of the mask in order to divert the oxygen and fill the reservoir bag. The volume of the reservoir bag is usually around 1 to 1.5 litres. This is greater than the inspiratory volumes that most patients will achieve, even when working hard to breathe, meaning that their entire requirement of air in a single breath will come from the reservoir bag and the oxygen inflow. During inspiration, the reservoir bag valve opens and the mask valve closes. This means that the patient breathes in the air from the reservoir bag, which contains a high concentration of oxygen. During expiration, the mask valve opens, allowing expired air out, and the reservoir bag valve closes, preventing the exhaled air from entering the reservoir bag. During this time, the oxygen inflow will fill the reservoir bag. This is why it's referred to as a non-rebreather mask, because you breathe in a high concentration of oxygen from the reservoir bag with each breath. We mentioned earlier how a Venturi mask is a fixed delivery device where you can control the FiO2 achieved. It's achieved by utilizing some clever laws of physics. At the bottom end, a certain amount of oxygen will be passed in via the tubing from the wall. If you look on the side of each Venturi device, it will specify the flow rate that should be applied. It varies depending on the FiO2 achieved by each device. Ignore the green color of the Venturi in this diagram. Let's pretend that this Venturi is designed to achieve an FiO2 of 24%. So let's say this Venturi states that 2 liters per minute of oxygen should be applied to the bottom of the device. It will then pass through a narrowing which will speed up the flow of oxygen. Imagine putting your finger over the end of a garden hose, creating a narrower and faster jet. At this point, the Bernoulli principle comes into effect. This states that increased fluid speed creates decreased pressure within that fluid. In the context of the Venturi mask, it means that the area of the Venturi mask in which the oxygen has been sped up has a lower pressure than the atmosphere. This then means that air from the atmosphere is sucked into this lower pressure area through apertures found on the side of the device. In general, a lot more air is drawn in through the apertures than is provided by the oxygen tubing, and hence a very high flow rate is achieved at the end, in this example 52 liters per minute. We can apply the same equation as before to figure out the FiO2. This example is of a 24% Venturi mask where 2 liters per minute of 100% oxygen is diluted in 50 liters per minute of atmospheric air, giving an FiO2 of 24%. Let's recap the key principles. Venturi masks are designed to dilute each liter of oxygen in a set amount of atmospheric air. The different Venturi devices vary in terms of the oxygen flow rate and the size of the aperture. To ensure that the ratio to which the oxygen is diluted achieves the desired FiO2, it requires a specific oxygen flow rate to be administered, and this is listed on the side of the device. To reiterate, you should only apply the flow rate listed on the side of the Venturi when using the device. Any deviation from this flow rate will mean that you no longer know the FiO2 being delivered. Importantly, Venturi masks achieve a very high flow rate, which exceeds the peak inspiratory flow rates that a patient is likely to be maintaining. For example, Brenda earlier on had a peak inspiratory flow rate of 40 liters per minute. If this Venturi mask was applied to her, we would know that all of her requirement of 40 liters per minute would be provided by the 24% oxygen coming from the Venturi mask, and she would not need to draw any extra air from the atmosphere. It is the ability to achieve this high flow rate that exceeds the peak inspiratory flow rate that enables Venturi masks to achieve a fixed FiO2. Finally, let's speak briefly about high-flow nasal oxygen therapy. This is sometimes referred to by its brand name Optiflow. It's a useful tool in hypoxic patients with a high oxygen requirement, as the oxygen is warmed and humidified, meaning that much higher flow rates can be tolerated than through a normal nasal cannula. Rates as high as 60 liters per minute can be achieved through a high-flow nasal cannula, and as this exceeds the peak inspiratory flow rate, it means that the FiO2 can be closely controlled. Not only does high-flow nasal oxygen improve oxygenation, the high flow rate can also improve ventilation by flushing the expired carbon dioxide out of the upper airways. It can also provide a little bit of positive airway pressure, but this is variable depending on a number of factors such as the flow rate, structure of the patient's airways, and whether the patient is breathing through their nose or mouth.